Good evening, friends. We are back again with the next edition of our online web activity. And today we are focusing on hepatocellular carcinoma, and we would be looking at the navigation of the treatment of hepatocellular carcinoma, various strategies. And I'm very happy to inform everyone and a very warm welcome to everyone who's on the program that we have 250 registrations already from 15 different countries. Our programs have grown in popularity, and we are getting registration from almost all over the world. Friends, we know hepatocellular carcinoma, though is not a common disease, it doesn't figure amongst the top 10 cancers in most of the population-based registries, barring Barshi, which is the rural registry in Maharashtra, where it reports as high as about 7.5% of the cancers and one of the common cancers in Barshi. We don't know the reason for that. And we also know that the incidence and prevalence and also the mortality of hepatocellular carcinoma is highest in Northeast India. Though this is a disease which doesn't occur in the very young and the very old, the majority of the cases figure out between about 40 years and 70 years of age, with an incidence rate of 1 per 100,000 when we combine both the genders. There is a decreasing trend of hepatitis B on account of universal vaccination, which is leading to a drop in the incidence of hepatitis B also. But yet, this is a disease which has a very strong viral association, and not to forget that alcohol also has a strong association through liver injury causing cirrhosis. And the newly coined, the newer definition, not the non-alcoholic fatty liver, but the metabolic dysfunction associated steatotic liver disease, which is called as the MASLD, bringing all the metabolic disorders under one umbrella, is the another cause, and this is increasing. Both alcohol and metabolic related are increasing. We diagnose, unlike many other tumors, diagnose hepatocellular carcinoma based on serology, based on the radiology and the radiological features. And the treatment, of course, there are three major areas of focus. Local therapy, organ confined therapy, which is listed out here, TACE versus TARE, and we have a very elegant lecture on that. The other treatment for a disease which is unresectable advanced is treatment with the small molecules. These are the tyrosine kinase inhibitors. And third is the new kid on the block is the immunotherapies for again for advanced hepatocellular carcinoma. So we have a keen focus on these three therapeutic areas, followed by a panel discussion. And I'm sure it will be a great learning activity and a lot of uh, take homes out of the discussions. We have experts on the program today, and welcome to all the faculty, all the attendees, and I hand over the proceedings back to you, Priyanshi, to take us through the rest of the program out here. Thank you so much.
Thank you so much, sir. So let us begin with our agenda. So first speaker, we have Dr. Somil Singhal from Medanta. And his topic is TACE versus TARE, strategic choices in the fight against hepatocellular carcinoma. Thank you, and over to you, sir. Sir, you are on mute. Yes, sir, you are audible.
Perfect. Thank you. Good evening. I'm Dr. Somil, and for the next 15 minutes, I will try to come out with the strategic choices in fight against hepatocellular carcinoma, and I'll mainly be focusing over TACE versus TARE. Now, as Dr. Vaid was saying, hepatocellular carcinoma is a rising health concern globally, and it's estimated that about 1 million patients annually will be affected by it by 2025. Hepatitis B still accounts for almost 50% of cases, and NASH cirrhosis is gaining pace as an etiology for HCC. Globally, we see that the incidence is between 5 to 20 patients in 1 lakh population, and the highest rate is seen in Eastern Asia and Sub-Saharan Africa. In India, the incidence is about 2 per 1 lakh patients, with a high mortality rate of about 2. Now, the best way to approach HCC is in a multidisciplinary format where we have the medical oncologist, we have the surgical oncologist, we have the radiation oncologist, we have intervention radiology, transplant, and the hepatology sitting across the table discussing patients, and each patient has to be dealt with in a tailored manner to give the best outcomes. Now, what are the treatment options available? The treatment options include surgical resection, transplant, local regional therapies, and systemic therapies. Transarterial embolization basically includes bland transarterial embolization, conventional transarterial embolization, that is the TACE, the conventional TACE, chemoembolization using drug-eluting beads, that's the DEP TACE, and transarterial radioembolization, that is TARE. Now, TACE and TARE function, the mechanism of action is similar, where an embolization is being performed. However, in TACE, we are using a chemotherapeutic agent and we are inducing hypoxia, whereas in TARE, we are delivering particles containing Y90, mainly Y90, which is commonly being used, into the tumor, and an internal radiation into the tumor causes tumor necrosis. Now, when we look at the arterial anatomy, we see that the arteries are the main feeders to the tumor, and these divide and further subdivide to capillaries. Now, when we are performing embolization using particles, like in depth TACE or in bland embolization, we are using 100 to 300 micron particles. As we move towards conventional TACE, the particle sizes go about 300 to 500 micron. And you'll notice that when we are performing radioembolization, the size of the particles is much smaller. As we go along, I'll tell you what is the importance of this concept. Now, when coming to TACE, basically we are occluding the arterial supply to the tumor in a super selective manner and inducing necrosis. So there are various chemotherapeutic agents that are being utilized. Most commonly, we use doxorubicin. There are other chemotherapeutic agents which are also used, such as cisplatin, gemcitabine as well. In conventional TACE, we are injecting an infusion of lipidol mixed with the chemotherapeutic drug. Whereas in DEP TACE, we are using polyvinyl alcohol particles, which are loaded with the chemotherapeutic agent. So this is how a conventional TACE looks like. So if you look at the image on the left, this is an MRI showing a well-defined lesion in segment 8. DSA image showing lipidol, which is deposited. You can see lipidol is seen really well when it deposits into the tumor. The third image is a DSA image where you can see there is very good deposition of lipidol within the tumor. And the portal veins are seen. This is what we call a good embolization when we perform a conventional TACE. On follow-up, there is complete tumor necrosis, which is seen in the MRI image on the right, and there is no recurrence or residual lesion seen at the site of treatment. This is a case of a DEP TACE being performed in a patient with a very well-defined large lesion in the left lobe of liver. You can see that the image in the center is a DSA image which we have taken. We have taken a Dyna CT after completing the embolization. And on follow-up, you see there is a very good necrosis with no residual or recurrent lesion. Now, transarterial radioembolization is also called as selective internal radiation therapy, or SIRT. Ideally, the right terminology to be used is SIRT and not transarterial radioembolization whenever feasible. So TARE is based on the principle where irradiation of the tumor is performed from within, leading to tumor necrosis. The most common used agent is Y90. So microspheres containing Y90 is injected into the tumor. So currently there are two commercially available products, that is the TheraSphere and the SurSphere. The difference is one is a glass sphere and the other is a resin sphere. Second difference is that the number of particles in a vial of glass sphere is less, and in a resin vial is more. And the importance of this will also be illustrated as I go along. So this is a case of a patient who was planned for TARE. You can see successive images. So TARE is being performed in two parts. So the first image on the top, you see that we see the MA being injected and the MA images are taken. And then the second row of images show a good deposition of the Y90 into the tumor on the PET image. And follow-up images on PET show complete tumor necrosis and no residual or recurrent lesion seen at the site of treatment. Another similar case where TARE is being performed in a patient with a large lesion with PVTT. The left images show that the tumor and tumor response after treatment, and the bottom images show the PVTT which was treated, and follow-up images show no PVTT. That is, the portal vein tumor thrombus has been completely taken care of by performing TARE along with SBRT. So what are the indications of TACE and TARE? TACE and TARE can be considered according to the new current guidelines that in very early, if the patient is not being considered for resection, ablation, or transplant. In intermediate stage, when there's multinodular HCC without vascular or extrahepatic invasion, as a bridge to transplant for downstaging and as well as for palliative. In cases who are contraindicated, so the list is similar for both TACE and TARE, except that patients with portal vein tumor thrombus is not a contraindication for TARE. However, it remains a contraindication in cases of when being considered for TACE. So now when we go to the older guidelines, the older BCLC guidelines, we can see that TARE did not find a place in the old guidelines. And that was because of studies like SARA and Survinib, which did not actually highlight the importance of TARE, and there was a very skewed nature of data which was being presented. Because when you look at the post hoc study from the same SARA trial, you will see that there was up to a 33.9-month median overall survival seen in the group of patients who have been taken up for TARE. However, what they noticed was that there were three important predictors for outcome. That was tumor burden, the ALBI score, and the dose delivered to the tumor. And they found that when all the three predictors were present, patients tend to live for almost 34 months, and which is a very good number when you're looking at patients who are being taken up for TARE. And what they found was the possibility of disease control was also related to the dose. So the message they were trying to give out there was that if TARE was done properly and the right amount of dose was delivered to the tumor, actually what we could achieve was a longer overall survival and local recurrence rate were lower. And hence this led to more studies being performed globally, trying to look at whether TARE had any role to play or not. Studies were being performed locally in India as well, where this was a study which was done at our center. They were trying to look at whether the tumor biology could predict the outcomes of recurrence in patients who undergo transplant. And they found that patients with moderate and high risk should be considered for TARE along with SBRT and even TACE in moderate group, and in high risk group for TARE as a downstaging strategy and to improve their outcomes post-transplant. So this was a study where patients with portal vein tumor thrombus, as I told you, portal vein tumor thrombus is completely contraindicated in TACE group. So patients with portal vein tumor thrombus are in advanced group of HCC. So what we have done in our center is combine TARE with SBRT in this group of patients. And what they found was the outcomes were really good because they could be downstage to transplant, and the overall survival and the recurrence-free survival was 48% and 40% at 5 years, which is really good when you look at it from a patient who has advanced HCC. And if they go to a center where this is not being considered, patient would be outright put on systemic therapy and with a chance of not undergoing transplant. So we can see that patient had a better overall survival and recurrence-free survival. Now, SIRT did not find a space in a guideline till now actually, and hence all of us were using an integrated guideline system at an institutional level, trying to adopt this strategy wherever feasible. However, in 2023-21, this landmark paper by Riyad Salem, where they found that TARE had a role, especially in patients with solitary unresectable tumors. They found that when TARE was being performed as a primary therapy or as a downstaging strategy to transplant, they had a 100% 2-year survival and a 92% when it was used as a primary therapy. And patients were doing really well when they were being considered, especially for as a downstream strategy for transplant. What they found was in 207 patients who underwent transplant post TARE, there was complete pathological necrosis, which was associated with lower HCC related mortality rate, longer recurrence-free survival, and longer time to recurrence. And hence, the main message this study tried to give out there was that when TARE is done properly and a higher dose is delivered, we can achieve complete pathological necrosis. And whenever complete pathological necrosis is achieved, the outcomes are favorable for the patient because they live longer with lower chances of recurrence. And because of this study, TARE found a place in the newer BCLC guideline, leading to a much more stronger position, allowing patients to be considered for something much more substantive, and it would lead to a much better outcome. Further studies continue to happen where we moved from performing just TARE to an ablative form of TARE where higher doses being delivered into the tumor, causing complete necrosis. And we see that conventional TARE versus ablative TARE, the median overall survival improved by almost doubling from 22 months to 45 months. Now the concept moved from performing just conventional TARE where 120 gray is being given to a personalized approach where higher dose is given to achieve higher amount of necrosis. We see that this study where patients were divided in standard dosimetry group and personalized dosimetry group. Patients in the personalized dosimetry group with higher dose being delivered to tumor had better outcomes in overall survival. And also patients with PVTT had a better outcome, especially in the personalized dosimetry group. So, and what they found was that SIRT had a bigger role to play, especially in PVTT group. You see that 44% of patients in the personalized arm were downstage, and not a single patient in the standardized arm was downstage. So the message, what they wanted to give out there is that the dose plays a big role, and a TARE which is done properly has a higher chance of giving better outcomes as compared to other treatment options. In 2023, the Puri guidelines had come out, and they incorporated TARE into their staging strategy, and they have recommended that TARE should be considered, especially in patients with advanced HCC, where outright patient would be denied any treatment, local regional treatment, I mean, and they should be given a chance to undergo transplant if after downstaging them. Newer studies are being performed all over the world where they're now moved from just uh, performing a TARE to performing a TARE done well and delivering higher dose to the tumor. So what we understood is that both in TACE and TARE, there is an immunological response which was always observed post-treatment. And this is what now we have come to understand, that there's an immunological response. And newer studies are being taken into consideration where they've realized that the microenvironment in HCC is getting altered after we are doing TARE, even TACE, and this causes significant immunomodulation. And because of this, there is a sustained response leading to a better outcome. Another study was done where they showed that there was an immunological response. Immunomodulation was at its peak at 1 month, and it gradually decreased over 3 to 6 months. And this is the time where immune checkpoint inhibitors should be given to enhance the response. And this led to studies being performed where they are combining ezetimibe both in TACE and even in TARE. These are the current trials which are going on all over the world where they're combining immunotherapy with both TACE and TARE, and they're trying to look at if they can improve the outcome further. Now, when you compare TACE to and TARE, what we are noticing is that the overall survival might not change. However, there is a significant improvement in both time to progression and median progression-free survival. So this was a study where they compared radioembolization with drug-eluting bead. And interestingly, they had to terminate the study because one of the wings performed much better than the other. And TARE showed that the time to progression and overall survival was almost double when compared to the DEP-TACE arm. And hence they realized that such a study cannot further continue, and they had to stop the study. When we look at meta-analysis looking into comparing the two, meta-analysis from 2018 also have shown that the overall survival and progression-free survival are similar. However, time to progression is almost 3 times higher in patients who are undergoing TARE. There's reduced dropout rates from transplant, and a higher proportion of patients are undergoing transplant in patients who undergo TARE. Similar things were seen in more meta-analysis where time to progression was better. And it does not differ when the size of the tumor is more than 5 or more than 3. Results have almost been similar in all groups. Now, it's completely understandable that TARE cannot be performed every time because there are definite cost constraints, especially in an economy like India where not every patient can afford TARE. Now, this was a consensus guideline where they said that if TACE is being considered, it's important that TACE should be considered along with ablation and not just as a monotherapy, because the outcomes of combining is better. And if ablation is not being considered, then a systemic combined with TACE has shown better outcomes. Whenever it is being combined, when TACE was combined with RF, there was better overall survival and recurrence-free survival. It does not differ by if we are performing RF or microwave. Both have shown similar results. And when we are looking at combining it with lenvatinib, the study has shown that the median overall survival, the median progression-free survival, and the objective response rate was much better in patients who were being were being considered for the combined therapy over monotherapy. Multivariable analysis have revealed that portal vein thrombus and treatment allocations were independent risk factors for overall survival in these group of patients. So the main takeaway out of my talk is that it's very important that all patients should be considered through a multidisciplinary approach. Between TACE and TARE, TARE should be considered every time it can be considered. If cost is a constraint, try combining over monotherapy because that holds promise for better outcomes. TARE can be considered for all stages of BCLC from A to C. Uh, Planning and dosimetry is very important. We have to be ablative, and it's very important that we stay ablative. And approach should always be personalized in these group of patients. Thank you for your time.
Thank you so much, sir. Moving ahead with our next talk, we have Dr. Ankur Varshne from Medanta, the Medicity, and he's going to speak on current frontline strategies for advanced hepatocellular carcinoma, role of TKIs. Thank you, and over to you, sir.
Hi, good evening, everyone. And as Dr. Somil had already stated about initiated the idea of HCC, I am going to share what, as a medical oncologist, I studied, especially in the systemic treatment.
Sorry to interrupt, sir. Can you do the slideshow mode on? Yes.
Okay.
Perfect, sir. Thank you.
So, starting, definitely, it is already been studied. Liver cancer is having a significant problem with it's the seventh most common cause of cancer worldwide, but the main topic why we are having this class is the high incidence of mortality. Despite being the seventh most, is the third most cause of global mortality because of cancer. And the situation is similar in India. If we look at the Globocon 2020 data, the incidence was reported at 31,259, and deaths due to liver cancer were reported at 30,404. See, the difference is quite minimum. So in India, liver cancer is the 10th most common cancer type and one of the leading cause of cancer-related deaths. It is a male preponderance with male to female ratio is 4:1, and median age, as sir told in the initial introduction, is around 40 to 70 years, and the frequency of this cancer increases with the increasing age. The incidence, definitely, it's most common the cirrhotic patients, the incidence averaging 1.6% per year. Most common cause is till now maximum that report is reported in the literature is because of the viral etiology. But now whatever the latest literature is coming up, it is saying that non-alcoholic fatty liver disease is also contributing to a significant extent to this SCC cause. And tertiary center across India report a burden of approximately 100 cases per year. And definitely, there is an increase in incidence in SCC with registry in Mumbai, Chennai, and Bangalore reporting the maximum cases. So the problem is approximately 45% of these cases, when reported at baseline, have an advanced disease. Either the disease has progressed to the lymph nodes or has gone to distant organ. And definitely, once metastasis is there, the prognosis is ultimately poor. And we can see clearly in this chart where 5-year survival in localized disease is 31%. But when distant met is there, the 5-year survival is lower down to less than 3%. So this is the BCLC staging and treatment choices. Definitely, I would like to discuss in detail. First, a very early stage is denoted with the child book A score, ECOG performance status 0, and when tumor burden is solitary nodule less than 2 centimeter. We have a curative intent, and definitely the case is lies in the multidisciplinary tumor board to either go for the surgical resection, or if case surgical resection is not possible, we go with the local ablative form TACE or TARE. In early A stage, the either child book can be child book A or B with a performance status 0. It could be solitary nodule greater than 2 centimeter or multiple nodules but less than 3 centimeter. Till these stages, the intent is curative with a good 5-year survival. If the disease progresses beyond it, that goes to intermediate B stage with child book A or B, performance status preserved. Multinodular disease, more than 3 nodules, or more than 2 nodules if any nodules is greater than 3 centimeter. So surgical resection is not possible in many of these cases, and we go with local ablative strategies as discussed by Dr. Somit. Coming to the advanced C stage, where it is childhood A or B, ECOG performance it is preserved. It has a macrovascular invasion or an extrahepatic spread, or the patient is not a candidate for liver transplant. So this come for systemic therapies. And when we discuss these cases, median estimated survival time range in 11 to 13 months only. In terminal D stage, it's childhood C, ECOG performance status poor, non-transplantable HCC, and definitely limited time span. Estimated survival is around 3 months, and treatment options we are left is best supportive care. So definitely this approach is being discussed, and we always highlight a multidisciplinary tumor board approach. And now what we have for the systemic treatment in HCC, as we see the evolvement of systemic treatment, the very first drug which produced a benefit was sorafenib, which was launched in 2007, followed by regorafenib, and then subsequently many TKIs got developed, lenvatinib, cabozantinib. Coming to the immunotherapy, in 2020 we got an approval for atezolizumab, bevacizumab, and now recently in 2022 we got an approval for temilumab and durvalumab. So now this is an advanced SCC management algorithm. I will not go in the intermediate category stage. Dr. Somil has already discussed this. In coming to the advanced stage, what maximum time we got, we offered systemic treatment, and initially with the involvement of many upfront drugs, either the first line immunotherapy combinations like atezo-bev or durvalumab temilumab, and if the patient is not feasible for these drugs because these drugs are costly, we can offer tyrosine kinase inhibitors which include lenvatinib and sorafenib. So these are the NCCN guidelines and recommendations. In first-line systemic therapy, the preferred choice of drug is atezolizumab, bevacizumab, which is category 1 in childhood A only, and temilumab plus durvalumab, which again category 1 recommendation. The other recommendation is oral TKIs, which include sorafenib, approved in childhood class A and B, lenvatinib in childhood class A only, can use a single agent durvalumab, category 1 recommendation. Pembrolizumab is a single agent, is category 2B recommendation. In certain scenarios, nivolumab as a child in childhood class B, atezolizumab in childhood class B, and if TMB high is present, there is an option of nivolumab and ipilimumab. Now we will study the separately data how these drugs were evolved. And the very first drug that was introduced was sorafenib. It was designed on the basis of SHARP trial. The recommended dose of sorafenib is 400 mg BD. Mechanism of action, this is a tyrosine kinase inhibitor, will inhibit RAF pathways, VEGFR pathways, PDGFR pathways. And this drug has shown a specific benefit in SCV-related cirrhosis, where this subgroup analysis has shown a greatest overall survival benefit. The adverse event associated with drug was diarrhea and head-foot reactions. The drug got approval with the SHARP trial, where it has shown a median overall survival benefit for the first time, with median OS reported with the use of sorafenib as 10.7 months, while in the placebo control arm, it was only 7.9 months. Coming to the Asia Pacific subgroup of this study, this Asia Pacific subgroup includes the 226 Asian patients, and the inclusion criteria was definitely the same. Childhood A was included, and in case the median overall survival was reported a slightly better, with median OS benefit was 10.7 months with the use of sorafenib as compared to the placebo, where it was only 7.9 months. So coming to the next TKI, which is approved for the treatment of SCC, is lenvatinib. This is approved as per the REFLECT trial. The dose recommended is 12 mg OD, and we can increase it and decrease it as per the patient tolerance. Mechanism of action is it against a tyrosine kinase inhibitor, which inhibits various VGFR, FGFR, PDGFR, and RAF pathways. This various studies has shown that this is a first-line agent in non-viral histology, but the adverse event associated with this use of this is hypertension, diarrhea, slight loss of appetite and weight, which may simulate with the disease also. Now, coming to this, the REFRACT trial, which has shown a better median overall survival as for the first line lenvatinib as compared to the sorafenib. Lenvatinib reported a median OS benefit of 13.6 months, while sorafenib reported a benefit of 12.3 months. So the first line combination approach, coming to the immunotherapy agents with other drugs. So we have the combination of atezolizumab with bevacizumab, which is category 1 recommendation as per NCCN. The drug combination was approved as per the IM Brave 150 study. And current status, we usually prefer this drug combination as a first line unless there are some contraindication with the use of bevacizumab or atezolizumab. The dose recommended is atezolizumab is used as a dose of 1200 milligram per milligram, and bevacizumab is used as a dose of 15 milligram per kg given every 3 weekly. Mechanism of action, definitely atezolizumab is a PD-1 inhibitor and bevacizumab has a BVEGF inhibition. So what's the data? The data shown in IM Brave 150 study with the use of the atezolizumab and the test arm controls the sorafenib. So the median overall survival reported in the atezobev cohort was 19.2 months, while the median overall survival reported in the sorafenib arm, it was 13.4 months. So we had a significant OS advantage, and at the 6 months overall survival rate, the 6-month overall OS rate in the atezobev arm was 85%, while in the sorafenib arm, it was 72%. So on the basis of this is the first IO combination which has shown a benefit of overall survival in HCC. Coming to the combination of immunotherapy with TKIs, we have LEAP studies where the lenvatinib and pembrolizumab combination was studied, and though the endpoint of this study was not met, whereas there was no OS benefit shown, but it has a slightly a benefit rate of reported, with the median OS reported was 21.2 months with the combination, and median OS reported with the use of single agent lenvatinib was 19 months. Coming to the another study, which was the COSMIC study, reported use of cabozantinib plus atezolizumab versus sorafenib. So the endpoint, the study reported a PFS benefit of 2.6 months with the combination rather than going for sorafenib agent, single agent. However, the OS benefit was not found to be statistically significant. So after the first line studied agent, let me proceed for the second line. What is us for in the second line after progression on the first line? So we have TKI, which is called as cabozantinib. It's an inhibitor of VEGF pathways and MET pathways. Celestial trial was there to show its benefit, and we have shown that in Celestial trial, the cabozantinib was given in the test arm and placebo was there in the control arm. The median OS reported with the use of cabozantinib was reported to be 10.2 months, while median OS in the control arm was only 8 months. So there is a marginal OS benefit of 2.2 months shown with the use of cabozantinib, and this has shown a better response in which prior therapy with sorafenib was given. So it's the TKI, which is the adverse event as related to the same TKI combination. It can lead to hypertension, liver enzyme derangement, fatigue, and diarrhea. Coming to the another TKI, which is again approved, is regorafenib. It's again a multi-kinase inhibitor. It has a significant OS benefit as compared to the placebo in SCC in second line. In the resource trial, when regorafenib was compared with the placebo, it reported a median OS benefit of 10.6 months versus 7.8 months in the control arm. And this has reported a significant higher overall response rate, but the drug is not recommended for the patient who has those sorafenib intolerant because of the overlapping side effects. Next is drug which is a VEGF inhibitor is ramucirumab. This is an anti-VEGF monoclonal antibody. The benefit is shown in the REACH2 trial, and the drug is approved for second-line treatment following sorafenib in patient population who has alpha fetoprotein greater than 400 nanogram per ml at baseline. It has shown a median OS benefit of 8.5 months versus 7.3 months as compared to the placebo, a better overall response rate, and disease control rate. The side effect recorded is were fatigue, peripheral edema, decreased appetite, and abdominal pain. So these are the various drugs which have been approved in HCC treatment. Thank you. Any questions?
Thank you, Ankur, for that wonderful lecture outlining the development of the therapeutics in the space of tyrosine kinase inhibitors and their combinations with IOs as well, and also dwelling on the VEGF inhibition. I think we have a panel discussion there. I'm sure there will be a lot of questions in the panel discussion, and we'll reserve our questions for the panel. Meanwhile, Priyanshi, are you there?
Yes, sir.
Please, you could carry on with the.
Yeah, sure, sir. So we have our next speaker, Dr. Rajat Bajaj from Fortis Noida, and he's going to speak on immunotherapy breakouts, transforming HCC treatment in paradigms. Thank you. I'll share your slides, sir.
Yeah, good evening. Am I audible?
Yes, sir, you are audible.
Okay, thank you. Good evening, everyone. I thank the organizers, Dr. Ved sir, and his team for having me here and organizing this webinar on the HCC landscape. How about how do we really go about improving our treatment modalities for HCC patients in 2024 and 2025 now going ahead. So in the next 15 minutes or so, I am going to talk about the role of immunotherapy in the management of HCC, and we are going to talk about and stick to mostly the first line treatment of advanced HCC. Dr. Ankur Vashne has spoken very well about the various treatment modalities which are there, and he has touched upon the important regimens that are there as far as the IO combination is concerned. I'll be dwelling more on them. So first of all, we all know that the epidemiology of liver cancer does tell us that it is the seventh most common cancer and fourth most common cause of cancer-related deaths globally, and this is Globocon 2022 data. Next slide, please. So it becomes important for us as clinicians, as medical oncologists, to delve deep into how can we really improve our metastatic HCC patients' survival. And more so when we see on the screen on the right hand side that if the patient is a metastatic case, then the 5-year survival is very dismal and it is less than 5%. Also, it doesn't really help when we see that approximately 50% of the patients are diagnosed when the disease has spread in the extrahepatic part, that is outside the liver, and then the intent of treatment does not remain curative. Next slide, please. Now, talking more about the epidemiology, like I said, that there are over 30,000 cases that are there in terms of incidence and similar number of deaths. It is a male predominant. It's a male predominant disease with a median age of 40 to 70 years that we really look at. And if we talk about the BCLC staging, which Dr. Ankur very clearly elucidated as well, we see that 50% of our patients are diagnosed in the advanced stage, which is BCLC C and D. So which means that we should have our good armamentarian going forward for such patients where we can give good treatment options which improve their overall survival, and also to a great extent, as much as we can, do not deteriorate the quality of life as well. Next slide, please. Now, there are various mechanisms as to how the HCC develops, and mostly it is inflammation and immune dysregulation. We also do understand that the various etiologies, being viral or non-viral related, which is mostly NASH, is something that has to be kept in mind, and that these etiologies also play a role in determining to a certain extent as to what will be the treatment plan first line for such patients. But mostly all these etiologies combined can lead to the development of an inflammation, which is leading to a dysregulated liver immune network, and ultimately leading to a fibrosis, cirrhosis, and then the tumor microenvironment has got an overexpression of CTLA4 and PDL1 that eventually leads to carcinogenesis. Next slide, please. Now, having all this in mind, the various risk factors, like I said, even substance abuse, ethanol abuse also being one of them, and a prime risk factor in our country and even the Western population. It is either viral or it is non-viral, and non-viral is further of two types: substance abuse, or it could be the metabolic causes or metabolic syndrome related, which is NASH. Next slide. There have been various studies about which etiology basically is preponderant in India or in Indian setup, and it has been seen that non-alcoholic fatty liver disease is much more common as compared to the viral etiology, at least in our Indian setup. Whereas in the Western population, we see that it is actually the other way around. The viral etiology, Hep B or Hep C related, is more common than NASH. Next slide. Next slide, please. So this slide has been shown by Dr. Ankur as well. This is updated BCLC staging system 2022. And here we see that if we talk about the advanced stage, which is C and D, probably not talking about D as much because there the patients would probably be resorting to best supportive care. But if we talk about C, we have options of either first line TKIs or option of immunotherapy. One is immunotherapy plus a VEGF inhibitor, and the other is immunotherapy with another immunotherapy, which is a CTLA4 inhibitor. We'll be talking about that in just a while. Next slide, please. So my talk is going to be centric on the immunotherapy use. This again has been spoken by the previous speaker, where we do understand that for years together, we had only sorafenib as one of the options or the best available options for metastatic HCC patients. After about 7 years of 2007 telling us about sorafenib, there was reflect study which told us that lenvatinib as a multi-kinase TKI is not inferior to sorafenib and probably better tolerated, and that is how it came into vogue in 2014 and onwards. After that, last 3 to 4 years have seen the advent of immunotherapy, especially in 2020 when atezolizumab plus bevacizumab combination came into being, and it was the IMBRAVE 150 study which saw the light of the day, and it was a positive study. After that, we have had 2022 having tremelimumab and durvalumab based combination, or the STRIDE regimen, being approved by US FDA, and now for the last few months this is available in India as well. Next slide, please. Now, talking about the SHARP and the REFLECT study, we've had these patients where the median OS has been to the extent of 11 to 13 months. Also, if we go to the subgroup analysis of these patients, we see that mostly these patients were the ones where the improvement in the overall survival was seen, whether the patient was having a hepatitis B or a hepatitis C. In SHARP study, there were mostly hepatitis C patients who were benefited with sorafenib versus placebo. REFLECT study was hepatitis B patients benefiting more with lenvatinib versus sorafenib. And REFLECT study was a non-inferior study, so that is what came into being, that lenvatinib can be used if the quality of life becomes better with lenvatinib compared to sorafenib. Next slide, please. Now, talking about IO combinations in the first line. IO combinations, like I said, IMBRAVE 150 actually was the guiding path. This was 2020, and very importantly, one has to understand that these were first line locally advanced or metastatic unresectable HCC patients, and preserved PS, and not only that, the Child-Pugh score had to be A, and they were randomized 2:1 to receive either atezo in the standard dose of 1200 Q3 weekly plus bevacizumab in the dose of 15 milligram per kg Q3 weekly, or the comparator arm was sorafenib, which was in the standard dose of 400 twice a day, and this was continued till acceptable toxicity or progression. the primary co-primary endpoints were kept as overall survival and the and PFS. Next slide, please. Now, this was a positive study, and one could see that the overall survival was improved with the use of atezo plus bev combination compared to the sorafenib in patients who were given this particular combination. But importantly, one has to understand that there are certain patients where this combination probably is not very fruitful. We all know that there are patients of liver transplant where post-transplant patients can develop hepatocellular carcinoma. Those patients are mostly on immunosuppressants and immunotherapy cannot be offered. There are patients where patients would have a high risk esophageal varices because of the cirrhosis part. This trial made it a point to have include patients who have had an endoscopy done in the last 6 months, and either the varices were not there or low risk, or if they were high risk they had to be banded. And that is, of course, this is a no brainer to understand. This was because of bevacizumab being included in that particular combination. Also important to note that these patients had an approximate 4 to 5 months improvement in overall survival, which was 13 months on one hand with sorafenib versus about 19 months with atezo plus bev combination. One can see the Kaplan-Meier curves here separating widely from the very beginning and separating till the very end. So this does tell us that it was a positive study with response rates of 30% vis-a-vis 10% in the sorafenib arm. Next slide. But importantly, if you look at the subgroup analysis, the non-viral patients, they did not improve as much, and one can see that the N or the number of patients also were not very less. They were about 150 out of the 500 odd. So does that really get us thinking as to whether this combination is important only for viral subgroup and not so much for non-viral subgroup? Probably yes, and we see that in the subsequent slides. Activate. So if you look at the safety and toxicity, one can see that the hypertension and proteinuria was there, which was more in the atezo bev arm compared to sorafenib arm, and that is something that we all keep in mind once we are giving this combination to our patients. Also, bleeding is a tendency, or the risk is more with atezo bev compared to sorafenib. Next slide. Now talking about the dual IO combination or the Himalaya study. So we have a rationale for it. I can probably skip these slides for the interest of time. Next slide. Come to the Himalaya study directly. So this Himalaya study, the background of it was that there was a phase 2 study which evaluated tremelimumab plus durvalumab in the escalating doses, and the final dose of tremelimumab was kept as 300 milligrams, and this particular regimen was then eventually found to be useful. It was found to be safe, and then was tested in the phase 3 study of Himalaya. Next slide. Next slide, please. Yeah, next slide. So this is the trial schema. If you see that these patients also were metastatic unresectable patients, BCLC stage B or C patients, and preserved PS with Child-Pugh score of A, and they were randomized again to a durvalumab plus tremelimumab or durvalumab alone or sorafenib in the 3 arms, and the primary endpoint was kept as overall survival. Next slide. This also was a positive study where the primary endpoint of OS was met, and the OS was kept as for the experimental arm was 16.5 months versus 13.5 months in the control arm. Next slide. Important to understand is that these patients received only one dose of CTLA inhibitor, which was tremelimumab, and after that durvalumab continued Q4 weekly in the dose of 1500. Next slide. Next slide, please. So one can see that the Kaplan-Meier curves, they separated early, and at 36 months, the 30% versus 20% was the overall survival that that one saw, and hence this was a positive study, improved the overall survival. Not only that, even the PFS and the overall response rates were improved. Overall response rates were about 4 times improved with the combination of dual IO versus only sorafenib. Next slide. Now, like I said, that there was an issue with atezo-bev, whether non-viral etiology patients, they actually have a benefit. These patients with the STRIDE regimen, be it any etiology, all of them were benefiting with viral and non-viral, both in the subgroup. Next slide. And the oral response rates I've already discussed. Next slide. And the side effects also did not they were not too many grade 3 and 4 side effects, and bleeding was not a major side effect. Next slide. So for patients where there is a risk for bleeding, probably a bevacizumab free regimen may have to be used, and this is one option that we have, which is now approved by NCCN and US FDA both. Next slide. This we've discussed. So in 2024 ESMO, there was a 5-year overall survival update of this phase 3 Himalaya study, and this was according to the ABLI score, which was albumin bilirubin score, which meant that they saw the liver reserve and the liver function, and divided patients into ABLI 1, 2, and 3, and found out that ABLI 1 versus 2 and 3 combined. Next slide. All of these subset of patients, they benefited with the use of STRIDE regimen versus sorafenib. Now, these patients would certainly be the ones where probably the bleeding risk would probably be more, and their dual IO combination scores over IO plus BEV, where the bleeding risk should not be offered to our patients. If you look at the other available options, we have the LEAP trial. Dr. Ankur also spoke about it. This was a negative study, but this is a combination which can be used where patients we would want as clinicians to for our patients to have higher responses, because in the LEAP study, this was the first study where IO plus TKI was used, and we've seen that IO plus TKI even in RCC combination has got higher response rates. The response rates in lenvatinib plus pembrolizumab was about 40%, which was not achieved with dual IO or IO plus VEGF inhibition. Also, lastly, I would like to touch upon the viral versus non-viral debate. Viral etiology patients certainly do well with TKIs. Non-viral etiology patients probably not as much with the atezo-bev. STRIDE is one of the options, but one has to understand that in the real world setting, it has been seen that atezo-bev patients also do not do bad. So the non-viral etiology patients do not do very bad with atezo-bev. So in the real world scenario, probably this particular discretion between viral and non-viral may not hold true at this moment till the want of more data. If the bleeding risk is there, bevacizumab free option can be used if cost is not a constraint. And if higher response rates are required, then we have the LEAP regimen, which is pembro plus lenvatinib. The patient has to be told that it was a negative study. The overall survival was not met. Only PFS and response rates were higher, but can be used because the safety data was met in that particular study. So with this, I thank the organizers for having me here and giving me the opportunity, and back to the organizers. Thank you.
Thank you so much, Dr. Rajat, for such a wonderful talk. So now we're moving ahead with our panel discussion. So we have Dr. Shyam Agarwal with us as a moderator. So welcome, and you can invite your panelists.
So I have the honor and privilege of inviting Dr. Shyam Agarwal to this panel, and welcome, sir. It's always a pleasure listening to you.
Thanks, Ashok. Yeah, pleasure to be in your team. Thank you.
So much. Thank you.
So, can you invite or should I?
So you can go ahead with the names.
Okay, I think I hope we have all the panel members. Dr. Shefali Sardana.
Yes, sir. Good evening.
Yeah, hello. Dr. Sanjay Bajal from.
Yeah, hi.
Yeah, welcome, sir. Dr. Kataria, I think, is there. Dr. Ankur and Dr. Vibhor Sharma.
Hi, sir. Good evening.
Right. So I think quite a few things have already been said. So let's have the first slide. I hope Dr. B.N. Kapoor is there or he's not there because he was the supposed to be chairing the session.
Sir, I am there, sir.
Okay, sir. I mean, you can make your. We love to have your comments before we begin. Thank you.
I do welcome Dr. Shyam Agarwal. He is a senior consultant director of Gangaram Hospital, and he is always there to do a very good job in panel discussion. And he will be speaking on immuno-oncology frontier, redefining HCC management. Dr. Shyam, sir, please.
Thank you. Thank you, Dr. Kapoor, sir. So I think we have a number of agents which are really coming our way, and particularly the immune checkpoint inhibitors, so which seem to be, altering the course of disease for patients with hepatocellular carcinoma. So we are a little short of time, but we'll try and cover a few new things in this particular panel. I think we like to skip these, the prevalence of HCC and all. So can I go to the next slide? Yeah, so I think this is an important figure which we should, remember in terms of numbers that, in our country, we have almost 35,000, new cases, and I'm sure the numbers would have gone up. And as you see here, majority of these patients are virtually, dying. So, that really talks about the unmet need which we have for the management of HCC. I mean, as you can see, this is the 10th most common cancer type and 8th most common for cancer-related deaths. So I think this highlights the need for, developing newer agents and newer modalities to help prevent deaths and maybe, prolonging the lives of patients with HCC. Next slide. So I think this is an important question. Dr. Shefali, what do you think is the other, causes or the risk factors for HCC in
Yeah.
Shefali, your thoughts?
Sir,
Next slide, please.
yes,
Yeah.
sir. So initially we thought that alcohol was the most common culprit, but now with the metabolic syndrome prevailing, I think NASH-related cirrhosis is superseding that. And apart for that, we have viral etiologies, some atypical factors leading to cirrhosis, which can damage liver, cryptogenic, and other things. So which we used to read in our MD times about that. So most commonly we deal with the NASH-related cirrhosis nowadays, sir.
So can I have the next slide? Yeah. So Dr. Bajal, what do you think? Because, you will come across more patients from referred from your gastro and the liver units. So do you think that the landscape in terms of etiology has changed from viral or alcohol to the NASH-related, the diagnosis? Dr. Bajal, sir?
I think so. I think we are seeing the change. We are seeing a lot of patients now in the second and third groups, no doubt, as compared to what was there in the last decade.
So any you would like to give attribute any figures to the NASH related? Is it like 50% or or
maybe there's a bias in our center and at our referral center, but I would say probably more would be MASLD and lesser viral etiologies for sure.
Right. So I think that's very interesting. I mean, that's food for thought for all of us, and particularly the physicians and the gastroenterologists, to really, highlight the importance of metabolic syndrome and, have some kind of, epidemiological studies and maybe some kind of interventions which should be looked upon. Anybody else wants to comment? Dr. Vibhor or Dr. Ankur, please.
Hi, sir. Same, definitely non-alcoholic fatty liver disease are definitely increasing, and there's an increased incidence of CLD followed by viral. Alcohol has taken a slightly a backseat, but it is a compounding factor in every case.
Okay, great. So can we have the next slide? Next slide, please. Yeah. So I think this is one of the publications which talks about the etiology of HCC, where almost 1/3 patients were due to the metabolic, followed by hepatitis B and C. Next slide. So I think let's come to the management part. Next slide. Next slide. Okay, so these are some of the dismal figures, which you can see even in patients with localized disease or regional disease. The 5-year, survival rates are really, really bad. So, Dr. Bajal, do you agree with this kind of pie chart and the 5-year survival rates, or you think things are taking a little better shape?
So no, so what I would say is that again, institutional biases would be very different. At our hospital, we are seeing a lot of early HCC as well.
Okay.
Maybe it's a referral that brings them here. We do see the advanced HCC, but predominantly, I think it would be an equal distribution.
Right. So that is what we are, showing here in this pie chart, that the localized are almost 44%, and the regional are and the distant, as you can see, 12%, and regional is 27%. So a large number of patients as per this. But Dr. Shefali, do you agree? I mean, do you see? I mean, I'm sure patients actually with advanced stage gets referred to us
Yes,
rather
sir.
than
So,
so what do you think the kind of stage at which you see the patients or you get the patients?
So nowadays, like Bezil sir also pointed out, that we are seeing the early cases also, because I think because of the certain reasons they are on follow-up of regular follow-up with the gastro team. So that is why the early cases are also picked up frequently now, rather than, I mean, we generally get the referrals in the advanced stages though.
So yeah, next slide, Dr. Vibhor. Yeah.
Yes, sir.
So, I mean, what kind of patients get referred to you? I mean, do you get only advanced cases, or do you get referrals from the IR team because of the new data which is becoming available?
Sir, we do get occasional referrals from the IR team because of the new data, but by and large, like 80% of the cases that we see are the advanced, 80 or 90% cases are the advanced stage only.
Right. So, most of the patients which get referred to the medical oncologist will, at least at this point in time, will have unresectable disease, and that too, not perhaps amenable to systemic therapy, to local therapy. So, but then Dr. Bajal, so, that's a interesting point in terms of the local regional treatment. What are your thoughts on the systemic therapy? How do you, approach these patients?
So I think I'm not getting the complete picture. Okay.
So can we go to the next slide? I think we can move on. So I think there's a need for the multidisciplinary team. I mean, that's quite obvious. We have the interventional radiologist, but you need also the radiation people. You need the liver surgeon and the transplant expert as well, so that we can, take a correct decision on the management of a patient with HCC because of a lot of things. Next slide. So yeah, so this is one of the slides, Dr. Bajal, which is one of the the BCLC stagings. So what is your approach for these group of patients with intermediate stage?
Right.
And so that's where your intervention perhaps, of course, even in the early stage, you can intervene in terms of microwave ablation.
Yes.
But then, so would you like to have your comments on your role and incorporating the medical oncologists alongside in patients with intermediate stage?
Sure, sure.
Yes, sir.
So,
Yes, sir.
I would say that BCLC, like many of the previous presentations, has matured from this to the BCLC 2022, where intermediate stage has been broken up into B1, B2, and B3. And similarly, the advanced stage also in the INASL recommendation, which was our in-house Indian Association of Study of Liver meeting that was held earlier this year and got published, broke up C into C1 and C2 because all of us understand that localized portal vein invasion is not identical to extrahepatic spread. So I'll come to that later. Coming back to intermediate stage, B1, B2, and B3 are the three groups. And B1 would be a large tumor more than 5 centimeters or multiple tumors well defined, where we would definitely offer local treatment.
So I'll just interrupt you. Can we go to the next slide? And the next slide. Yeah.
Yeah.
Right. So yeah.
So here, if you look at the extended liver transplant criteria, that would basically be beyond UCSF, and the strategy there would be to try to downstage those patients and bring them within UCSF / your institutional criteria and get them to transplant with intention to cure. So we very aggressively go after those lesions with focused treatment into the liver. The well-defined nodules in between, and if they have well-preserved portal flow and the liver functions are good, it would be a toss-up between TACE and TARE, and we saw Sawmill's data, which he presented at the beginning of today's session, where he talked about Y90 being a better strategy than TACE. And even in the diffuse infiltrative bilobar, they are actually the bad tumors.
Yes, sir.
And there we've been able to develop certain criteria to define amongst these which are the worst, and that would be the diffuse infiltrative ones. They would be the ones who would be PET avid, the ones who have very high alpha fetoproteins. Those would be the ones in whom we would definitely very strongly require your help after focus treatments.
Okay, so what I'm getting from you is that patients who have this diffuse infiltrative extensive bilobar liver involvement, that's where you would like to have the involvement of the medical oncologist.
Yeah, I think because I don't think without that help we would have any chance of actually substantially downstaging them.
Okay, so Dr. Shefali, what are your comments on use of TKIs in this intermediate stage alongside TACE or
yes,
TARE?
sir. Yes, sir. So TACE with lenvatinib or TARE with lenvatinib, we generally tend to use in the intermediate stage HCC, where we think that, there are two scenarios where we use them as a bridge over therapy to transplant, like sir mentioned, that to downstage or to downsize the tumor and then take them up for transplant. Or if there is a bilobar involvement, then we use TACE sometimes for the bigger lesion, which is more troublesome, and then maintain them on TKIs. That is also one of the approaches what we sometimes use in patients where we do not give the
I
yes, sir.
think my only point is that Dr. Bajal pointed out these three subgroups.
Sure,
So
sir.
are you going to be using the TKI in all three subgroups, or so that's where we need to have some kind of consensus or some kind of view of maybe all the medical oncologists.
So in the subgroup where sir mentioned, like diffuse infiltrative type,
Right.
there,
So that's
yeah,
where it's clear, but somebody has
yeah,
well-defined nodules, preserved
yes, sir.
portfolio. So will there be data to support the use of TKIs?
So only as a bridge over therapy where they require it prior to transplant, otherwise no.
Anybody else, Dr. Ankur or Dr. Kataria, please, any comments on the TKIs in this intermediate group, different subgroups of intermediate?
So definitely, as Dr. Shefali has said, in a diffuse infiltrative disease, we go ahead with the lenvatinib. And in certain patients where transplant is being waited or the donor is not available or some reasons, we can offer it as a bridge to transplant. So this is a very limited patients who come to attend our OPD.
Right. So Dr. Bajal, what do you think? I mean, should we be giving lenvatinib, or have you been sort of giving lenvatinib to all subgroups, or only limited?
No, so I think we've been using it, like was mentioned, predominantly in B3, and our push is towards getting them to transplantation in B1 and B2
And there,
with local regional therapies along.
so you will be just doing the TACE or TARE and maybe downstaging it for, making it maybe coming into the Milan criteria, and not using the TKIs, right?
I don't think in South Asia anyone is actually working within Milan. The transplantation criteria are so far now extended that
Correct.
virtually every institution has far beyond, in fact, even UCSF, to be honest. But it's a logical thing to say that outcomes within UCSF definitely would be superior to outs beyond UCSF. So the effort would be to at least get them into UCSF. But Milan is too restrictive, I feel.
Right. So, I mean, I think 5 centimeters and less than three lesions. So that's very restrictive. I fully agree. Can we move on? So I think, Dr. Bajal, if you were to say the patients were referred to you, what percentage are intermediate stage? And I think this is another important issue of child PUG score.
Yeah. So if we talk of, again, I'm sitting in such a large liver transplant center that the patients who predominantly come to us are the ones who are actually very early HCC with very good preserved liver function. But intermediate HCC with BCLC, with basically a child's PU, maybe B6, B7, and a tumor burden which is within the institutional transplant criteria, go to transplant. So in our center, we would see less of these patients. We would see the very early ones for ablative strategies with preserved liver function, and we would see more of the advanced ones for whom we have to downstage them. So our percentage of pure intermediate HCC is not that high. And as far as the percentage distribution of childs is there, it's B7 or less.
Right. Shefali at max, what do you think?
So these patients do not actually turn up to us in the initial stages, so I don't have that percentage numbers. But of course, I mean, child PUG B7 or 8, we now tend to see once they are referred for that IR procedures and all. So otherwise, I don't have numbers, sir. I'm sorry.
Right. So, most of these intermediates are referred to, the interventional radiologists for, I mean, they doing the TACE or TARE, and I think a lot of gastro people and even maybe the IR put the patients on TKIs, and they seldom get referred to us. So, that is a matter of concern, but things may change a little when we see some next slides. Next slide, please. So I think we can skip these slides in the interest of time, because let's focus on the Emerald 1 study. Next slide. So I think this has been already discussed. Next slide, please. Next. Yeah, I think we covered a lot of this. Next. So I think this is something which is becoming now important. The use of TACE along with immune checkpoint inhibitor and an anti-VEGF. And to this effect, next slide. The Emerald 1 study, a phase 3 study, was randomized placebo-controlled study of TACE combined with Durva with or without BEV in participants with unresectable HCC eligible for embolization. Next slide. So this was a 3-arm study in which patients had undergone TACE and which could either be chemoembolization or with drug-eluting beads. And this was followed by Durva, followed by Durva and placebo for Bev, Durva plus Bev, or Durva, so these are the basically the two arms here. Okay. So this study basically showing you that TACE alone is inferior than as compared to Durva plus Bev plus TACE. And the median PFS improved by 6.8 months. And you can see here the 12-month PFS and 18 months PFS. So, Dr. Bajal, what do you think? I mean, and this is significant statistically.
Absolutely agreed with you that if TACE is being used and not CERT, then I think this data is very strong to suggest that combination is the way to go.
So has that come into practice in your institution now?
I think maybe limited. We do get a smattering of such patients because if these patients for some reason are not undergoing transplant, which is a very uncommon scenario in our institution, because most of these in our institution would be transplant eligible, the intermediate group. So probably the patients in this group would be the ones in whom we are doing loco-regional transarterial treatments, who have the bad tumor biology markers in the sense of high secretors and beta-avid and diffuse infiltrative. Those probably would be the patients who would go through this line, this strategy.
So what's the time to decide that this patient should be subjected to, durvalumab and bevacizumab? So once you've done a TACE, so would that selection be upfront or, subsequent that you don't respond and then you want to add D and B? So, I mean,
No, because the thing is
what
that
is the binds? I mean, how does it work out? Yeah.
So it'll have to be upfront because the criteria for defining TACE failure is also very clear, of at least having done TACE 2 times and seeing tumor progression. So which probably we don't have that much of flexibility with such patients. So it should be an upfront strategy. I agree with you there.
Can I go to the previous slide? Anybody else wants to comment on the strategy for selection of these patients? So if you read the fine print here, the prior use of TACE or TAE is acceptable. It was used as part of therapy with curative intent, but not if it was used as the sole modality in curative therapy. Durva oblique placebo started 7 or more than 7 days after TACE, and one could use the beads, and that or the TACE. Participants will receive up to 4 TACE procedures within 16 weeks following day 1 of their first TACE procedure. So, Dr. Bajal, is this practical to give 4 TACE procedures within first 16 weeks?
I know this is a very daunting task. I would definitely agree with you that I don't think this can be replicated outside of a trial.
Right.
Is my feeling.
So, I mean, that's what since this data is there, and I think the international approval is there for using the D and B following TACE. So, who are those patients where we should be, refer? I mean, maybe you have to take that call because patient is in you,
Right.
and of course, there may be a multidisciplinary tumor board. So, we need to come to some kind of a consensus to
Agreed.
decide who are the patients who should be
Right.
offered this Emerald 1.
So my understanding would be intermediate stage, more than 5 centimeter size lesions, or more than 3 lesions, the sum of them being 8 centimeters, at least beyond UCSF. And like they mentioned, child's A to B7,
Right.
without portal vein tumor thrombus. Here, interestingly, they, I think, have included VP1 and VP2.
They
Tumor
have.
thrombus in this study group.
Yes,
And
yes.
they
And there is
excluded only the lobar and the main portal veins from this. So in our institution, since we have a different protocol running of SIRT plus SBRT, we actually don't go through this. But so like I said, for patients who are not going through the SIRT, SBRT and systemic therapy strategy, and they're going down the TACE arm, I would be more tilted towards doing an upfront decision of TACE followed by these
Absolutely. I
combinations.
think some thought needs to, Dr. Shefali, your thoughts, please. And then I think I'm
Yes, sir.
go because I have another commitment, please. Yeah.
Yes, sir. What I think is I agree with sir that upfront definition and defining those selection of patients is very important. And like one or two sittings of TACE and then selecting the patients that who would be candidate to go for Durva and Bev combination to have that advantage. I think that should be the way in our setting.
So
So
one or two, you
for
say one or
TACE,
two. I mean, the
for
protocol is only one,
Yeah, sir. Two, I'm saying that there sometimes we see the response, but I mean, we want that, like sir told that beyond UCSF, that you want to bring them into that criteria to have that better advantage in those scenarios, actually. Four days in 16 weeks is not practical, I think, in our centers.
Correct,
Yeah.
right. I mean, that's what, I mean, I thought I'll read the fine print. So Dr. Ashok, I think you're there.
Yes, I'm there.
Yeah, please. I think this is an interesting study which we need to incorporate into our practice because of the approvals. But then I think, as we all understand that, the studies are conducted on very well selected patients and fit patients and so on. But then I think we need to find a place for the Emerald One in collaboration with our gastro team and with the interventional radiologist so that we can provide the benefit of this combination to our patients.
That's a great point, Dr. Sham. And there is a stratification for portal vein involvement versus no involvement in this. So the SBRT, what we've been doing all along, I think this is a new alternative to the SBRT. And then given the delta, one can see the survival curves which are so well separated. And 12 months, it's almost
So I
about
think this needs a little more time and discussion, more, pooling of heads as to who are our patients who can benefit from this MRL one. Dr. Bajal, I think, and their, team members and ours, for example, Arun and Ajit, etc. Dr. Bajal, I think you really need to help us, or maybe, all of us need to have some kind of protocols which can incorporate DNB in the intermediate stages.
Totally agreed. Agreed.
Right.
Thank you so
So
much.
Dr. Ashok, there's another meeting I have to please go to. I don't mind if you can carry on or you let me go, please, because
We are really very grateful for that
no,
insightful
I
and very
feel apologies. I'm
no,
loving this debate, but then and this discussion, but then yeah, please let me go. Yeah.
please.
I
So,
must say, Dr. Shyam has very nicely discussed the use of durvalumab followed by TACE. And this is a new concept, and probably we can incorporate in our treatment options. And this is a new thing which probably one can start it. And use of newer immunotherapy which have come in the management of hepatocellular carcinoma. Probably with all this, the dismal outcome which HCC has may change over the years to come, and probably we will have better outcome in patients of HCC.
thank you very much, sir. Thank you, Dr. Kapoor. And I take this opportunity to thank everyone who has energized these efforts and given us really an academic feast over the last 90 minutes. We have had excellent lectures on the local therapies, on TKIs, and immunotherapies. And towards the end, we have seen how the paradigm is moving and newer therapies are stepping in. And now we have a non-VEGF combination of Durva plus tremelimumab and for a defined group of patients. And for the new paradigm which is emerging from A to B7. I think these are interesting times. I thank everyone. Dr. Bajal, thank you so much. It's been a privilege to have you on this program this evening. And Dr. Sham in absentia, all the panelists, the faculty who have delivered lectures, not last but not the least, all the attendees. At one point in time, we had more than 130 live people and more than 250 registrations. We hope to come back on the 24th. We have a program on lymphomas. This is the post ASH wrap up, and we'll bring you more interesting data on the management of lymphomas. I thank Priyanshi, Rajesh, and Mice Ideas for the backend support and for such a wonderful dissemination of information to people all around. With that, we come to the end of this session. Thank you so much. A very happy new year and a good night to everyone. Thank you so much.
Thank you.
Thank
Thank you, sir.
Thank you.
Thank you.
for giving the opportunity to come and attend this wonderful evening. Thank you very much.
Pleasure,
Thank
sir. Pleasure has been ours. Thank you so much. Thanks, everyone.